there's a study that came out showing that people who use nasal saline irrigation on a regular basis for years, when they had them stop doing the irrigations, the rate of sinus infections was much lower if you stopped the irrigation. So people who use saline irrigation on a regular basis had a much higher frequency of sinus infections. So they went to the doctors more often for antibiotics and allergy medications. So that goes along with this theory that, yes, it's helpful in many ways, but for some people it can be detrimental. So I'm not saying you should just stop using saline on a regular basis, but you kind of have to use it judiciously. So a lot of people just use it on an as-needed basis. And if you find that it works when you're using it, keep using it. If you stop using it and your problems come back, then go back to using it. So you really have to customize how you use it for your own purposes.
You're talking about any kind of saline, whether it's the neti pot or the spray.
Right. Well, the saline, what I mean by saline is there's different ways of getting salt water into your nose. So you have the neti pot, which is the teapot you just pour into your nose using gravity. You have the aerosol cans, the spray bottles. It's just different ways of getting salt water into your nose. They even have the Grossen irrigator. It's like a water pick machine that you hook up and just under high jet pressure irrigation, you can do that way too.
So you're suggesting that any one of them could have that effect?
Yeah, long term. But not in everyone, but for some people, yes.
So if you wanted to just prevent yourself, just on the chance that you might be having that response, would you say like use it 6 days a week, or use it 1 week, 3 weeks, and then don't use it for a week, or you be just as needed?
You know what? You kind of have to develop a regimen of your own. Everyone has their own regimen, and so what I'm suggesting is, let's say you're using the nasal saline and you still have problems, then maybe just taper off slowly and see what happens. Okay, or some people may have to do it more often. Okay. All right, so let's talk about nasal surgery. So we talked about all the conservative options. We only considered this after we tried all the conservative options, including allergy avoidance, allergy medications, even allergy shots, not eating late, not drinking alcohol. All these things we talked about you have to start with. But if that fails and your nose is still stuffy, then we start to talk about nasal surgery. Now, as I talked about before, there are two major benefits for sleep apnea patients. You're going to breathe better in general. Number two, you're optimizing your sleep apnea treatment therapy. Okay? So the common operations you're going to see is a septoplasty, terminoplasty, valve repair, adenoidectomy, sinus surgery. There's some other variations, but these are the 5 most common things you'll see. But you have to realize that each one of these procedures, it's a very generic term, and there's different variations. Okay. Now, let me skip over this. I talked about the fact that when I do a septoplasty, in many cases, we can lower the CPAP pressures. And in many cases, it also lowers the rate of sinus infections, too. Okay. So septoplasty. So not everyone who has a deviated septum needs a septoplasty, because it's not just how crooked your septum is, it's what's happening around the septum that's just as important, if not more important. But let's say that you have the typical standard crooked septum, and let's say you have, your nostrils are not that flimsy, they're pretty rigid, and you have enlarged turbinates, so that's a standard situation. So in that case, if medical therapy fails, then I'll offer a septoplasty and a terminoplasty. Now, the other thing is that as I said, you have to address all the other possible areas. And one of the most common reasons why a septoplasty doesn't work is, let's see, the septoplasty goes well, everything goes smoothly, and 6 months later, your nose is still stuffy. What usually happens is that you find that the nostrils are still caving in, so you always have to test for that. And now, how do you determine, well, which operation do you do? And it's a challenge because, as I said, if your nose is stuffy on the inside, as you breathe in, everyone's nostrils will cave in to some degree. So what I do, and I know I'm going back on what I said before, what I do is I have them use Afrin just once or twice. So what Afrin does is it shrinks your turbinates, so that's kind of like a temporary version of a septoplasty. And so if you can breathe really well after the Afrin, then we just stick with the septoplasty and terminoplasty. But if your nostrils still cave down, so let's say you use the Afrin, you can't breathe any better, you do this and you can breathe really well, then we also need to stiffen the nostrils.
How much would correcting a deviated septum help someone like myself has severe, I use CPAP and I have severe CPAP. So, I mean, I know you didn't examine me, but I'm just wondering, is that something that you would recommend to have, have surgery to correct the deviated septum?
Well, it depends on if you have subjectively, if you have nasal congestion, and also how deviated your septum is. But as I mentioned before, just because you undergo the surgery doesn't mean it's going to cure the sleep apnea.
I know that.
Yeah. So it has to be, that decision is made on an individual basis.
Well, nothing to do with me. I realize you put on the congestion, but I just said in general that it's correcting a deviated septum will help some of the sleep apnea.
So going back to the study I mentioned, if you correct the deviated septum, so let's say you're congested and you have a deviated septum, you correct it, that only cures sleep apnea in 10% of patients. So it does work in 1 out of 10 patients, but for most others, it doesn't make that much of a difference.
But you still breathe better.
You still breathe better, right. Your quality of life is much improved. Okay. So, there's different ways of doing septoplasty, and I know if you read the internet, you can see all these horror stories about pain, nasal packs, and bleeding, and pure misery. And honestly, I don't have that experience. I'm biased, but I think the key here is, ever since I kind of realized what was happening with the nose and sleep apnea, many years ago, I stopped using nasal packing. Now, personally, I remember I broke my nose when I was 6, and they put packings in my nose, and I remember having them, for a week I had these packs in my nose, I was miserable, and they take out these 6-foot-long packs. Now they have these sponges, so it's not as bad. But having something in your nose, it just aggravates sleep apnea. So what I do is, it's a modification where I spend a little extra time and I sew the mucous membranes together using a dissolvable suture. So it takes a little bit longer, but you don't have to use packing. I have not used packing, maybe I used it once in the past couple of years just for bleeding, but patients are much happier without packing. I don't even use splints. I just sew it up and that's it.
And you still get the black eyes like somebody else?
That's only if you have to break the bones for like a nasal procedure. For septoplasty, there's no change on the outside. So after the operation, you're breathing really well. But what happens is, over the next few days, it starts to clog up because the mucus in the blood will clog up your nose. And usually I have the patients come in 2 or 3 days later, they clean everything out, and you're breathing much better again. So, and most people take about 1 or 2 days off from work. Yeah.
So you're not under
Well, in most cases I do it on the general, sometimes I do it on the local. It depends on the situation. Yeah. Yes?
That's how common that is? How cutting edge is that? I mean,
I'm sure I'm not the only one, but I know a lot of people use splints with a dissolvable, like what's called a Telfo pack, just to kind of keep the splints together. Because the fear is that if you don't use packing, because what you're doing is you're peeling the mucous membrane off the cartilage along both sides of the cartilage. And you're creating this pocket on both sides, and you're removing the deviated septum, and you have to put the mucous membrane back together again like this. And so traditionally what you do is, that's what the packs do. It just kind of presses everything together so everything heals. The danger or the fear is that if blood gets trapped within that pocket, it kind of balloons open, and you get this cherry tomato-like picture. And then that cuts off the blood supply to the rest of the cartilage, and your cartilage just dies off, and your tip drops. So that's like the scary, yeah, I don't know if he had that, but that's like the common fear that all ENTs have when we're training, that you have to avoid that. But the way I do it, and I know a lot of surgeons do the suture, but they also use packs. But what I found is that you don't even have to use splints or packs, and my complication rate in terms of adhesions and redos, it's minimal to negligible. I was thinking about publishing my results, but I just don't have the time right now. So that's my personal bias, but I mean, just because you use packs doesn't mean that it's the wrong way to do it. And unfortunately, to suggest that to a surgeon, that they're going to be a little bit offended. I mean, there's just human nature.